Hey guys, let's do US healthcare, 5 key facts. Let's get into this incredibly complex, mind-numbingly complicated thing that once you get on the inside of it, you know some of the basic ways that the system works, then you can follow all the rest of it. And like you feel like you're speaking another language because you know all the acronyms and all the programs, and you can see how it all connects to each other. I'm going to turn my video off so I can really get focused on this PowerPoint. I love it. I love the top. Okay. It is complex, and what we need is we need some entry points to understand the broad outlines. Number one, the first thing to know about US healthcare is that healthcare is different than other parts of the economy. It has really high fixed and sunk costs and really low marginal costs. And that's important, and I'm going to explain that because once you know that first, you're like, oh, I get why the insurance companies play all these financial games with us, the patients, and the hospitals. Take this MRI. A hospital buys an MRI machine 5 years ago. They charge $1,000 an MRI. Maybe by the end of the first year, they've paid off that $1 million MRI machine by charging $1,000 an MRI. Well, they just keep charging $1,000, even though after year one, it, it could be free because the machine is paid off. High fixed and sunk cost means that the cost of the first MRI that you ever do costs $1 million. You have to pay $1 million for your first MRI. The second MRI is very low cost. And by the end of year one, theoretically, it's just the extra electricity that runs to the machine. Contrast that with a house. If they're building 10 houses and your property's right next to the people building 10 houses, and you think, oh, low marginal costs on things, let's just build a 13th or 11th house. And you go to them and say, hey, I'll pay whatever one extra house is. Well, add up the cost of one extra house, and it's still really expensive. So in healthcare, like in higher education, you can have a classroom with 20 students, and I'm giving my lecture, and a 21st student just comes in on a tour and sits down and decides to stay in college. The cost to the university is zero for that one extra student. Everything else has been paid for. My salary is there. It's taken care of whether I have one student or 21 students. The building's paid for. The machines I'm using to give the lecture are paid for. The fact that most of the costs in healthcare are way up front, and then one more of anything, one more pill, one more MRI, one more night in the hospital, it's very, very cheap, plays into the second point, which is you have one set of doctors and nurses, pretty much. The Veterans Health Service and Indian Health Service are slightly different, and they're separate, and they're not that big. But almost everybody in America who gets healthcare gets it from pretty much the same doctors and hospitals. But all of us who get it have such different health insurance programs. Some people have Medicare, they're old, or they're over 65. Some people are low income, they have Medicaid. People who are privately insured have tons of different private insurance companies covering them. And they all go to the same hospitals and doctors, and they negotiate knowing that the things they're paying for don't really cost that much once they've been financed over some period of time. And so they're always trying to pay as little as possible, which also feeds into something that you all learned about in the assignments today, which is we don't really have a standard set of prices for healthcare in this country, with one exception. Medicare pays pretty much the same thing everywhere. And that's a really key point. But look at this. What does an MRI cost in Dearborn, Michigan? Well, it depends on what kind of insurance you have. This is the list or charge master price. This is just like the absurd. They call it the rack rate in hotel. It's just the monopoly made up high price that they then have to negotiate down from. And if you come in with cash and you pay $700, they'll take that as payment in full. If your insurer is United Health, United Health's going to pay a lot. If you're Cigna, you're not going to pay a lot because Cigna is a big insurer in this area, and they can negotiate because they're big. They can negotiate prices down. I have a little asterisk here by the Medicare rate. The Medicare rate is usually the lowest, and it's the one that everybody knows. Like these, you don't know until someone does research and flushes these prices out. You can't even hardly get a charge master price. That's something that most hospitals keep to themselves. This is the one price in the country for most procedures and services that everybody knows about. And that's why Medicare is such a powerful and important program, because its prices are standardized and transparent, where most hospital prices and healthcare prices and medical procedure prices are not transparent. You don't know. Um, Look over here in Nashville, Tennessee. What does a colonoscopy cost? Well, it really depends where you get that colonoscopy. The professional fee, what the gastroenterologist gets for doing the procedure, doesn't vary a whole lot. But which hospital, which outpatient clinic, which facility does it? It might be a teaching hospital. It might be, who knows? There's a lot of reasons for this variation in the facility fee. This could be doctor's offices. This could be a big hospital. Reference pricing just says, hey, we're going to look at the average price and say that's what we'll pay for a colonoscopy as an insurer. It's a way to kind of get these high ones to come down. But just look at all of that variation. You watch the TED Talk, and what if all U.S. healthcare costs were transparent, and how that would help bring down the really high costs and add some sort of rationality. You can go to this website, Clear Health Costs, and get estimates. Now, the tricky thing about these is that these are variations in list prices usually. It depends on what your insurance covers and how much it covers. So these just give you a ballpark figure, but it shows like some places are really affordable. Other places just seem like it's a scam. Another website you guys can go to if you want to like compare prices when you're shopping. That brings up an interesting point. Do people shop for healthcare on price the way they do for cars and consumer goods? And the most research says not really. That people don't go around trying to get the cheapest heart bypass procedure as possible. So sometimes the price mechanism doesn't work in healthcare because people aren't thinking that way. Fun fact question. It just shows you sort of some of the craziness with billing and payment in U.S. healthcare. What's the number one reason people go to the hospital every year? What's the number one principal diagnosis? Some people know this and they guess it, but most people don't, and it's having a baby. Pregnancy, childbirth, and newborns, about 3.5 million a year. Women have babies at the hospital. You would think that if that's the case, you would have a pretty good idea of what the cost of having a baby is, if it's a complicated delivery and if it's a non-complicated delivery. Well, guess what? You can click on this. It's just a really fun, it's a Vox video about this guy whose wife is delivering a baby, and they're trying to estimate the cost of it. And they kept calling around and around and around. Nobody would give them an estimate. They said, we can only tell you after you have your baby. This is just also one of the interesting billing charges. They billed a woman $39, $40 for skin to skin after the C-section for taking the baby, putting it on her chest, which is you're supposed to do anyway. They charge $40 for it. So look at your medical bills. They can get crazy sometimes. So here we are again as the world's largest healthcare spender, in part because we have the highest prices. Right? It's not because we have the most amount of care. You might think, well, we spend the most because we do the most. We have the highest volume of consultations and hospital discharges and hospital bed days and all-cause length of stay. Nope, middle to the lower part. The reason we have the highest spending is we have the highest prices. We just, everything costs more for the same thing in the United States as compared to all these other countries. Right? Outpatient procedures, we have the highest prices. Prescription drugs, we tend to have the highest prices. Sometimes our generics are a pretty good bargain, but the generics can get out of control too. And this brings up this point that value in healthcare equals outcome divided by cost, or value in healthcare equals outcome divided by price. Cost and price are interchangeable. Think about this. Value in education equals the outcome you get for it divided by the cost and what you pay for it. Value in anything equals the quality of the outcome divided by the cost. And that's why U.S. healthcare is a low value thing, not because the quality isn't high. The quality is really high. We have some of the best doctors, nurses, and other allied health professionals. It's that we overpay for it. Angus Deaton and Ann Case, really famous economists, have studied this the last couple of years. In their estimation, every American family basically pays an $8,000 extra tax, a poll tax, whatever they're paying in taxes. The U.S. and the way we pay for healthcare means that every family coughs up an extra $8,000 and gives it to the U.S. healthcare system as a tax. We don't really do that. We don't actually see a tax bill that says U.S. healthcare, $8,000. But our overpaying for everything in healthcare means that collectively we're all paying $8,000 extra dollars for something other countries get for $8,000 less. And I say to all of you out there listening, can you think of things you'd like to do with $8,000? Do you have some needs that could be met every year by $8,000? I can. And that means we have a U.S. health spending problem. What is that health spending problem? In a simple, succinct way, the answer is opportunity cost. The more we spend on healthcare, The 8,000 we give up every year is 8,000 we can't spend on paying down student loan debt. It's 8,000 and more we can't spend on K through 12 education, transportation, the environment, tax cuts, debt relief. Anything else you want to spend $8,000 plus on, we can't do that because we overpay for healthcare. Opportunity costs are huge. And this speaks to this tension, this thing that we really struggle resolving, which is we think of healthcare as a really humanitarian, special, sacred calling, and it is. Excuse me. It is. I mean, the people who work in healthcare, by and large, are drawn to it to help people, and they help people through some of the worst things in life and some of their lowest points, like these clinicians, Heather Marin and Dr. Paul Kalanithi. I mean, awesome. The kind of thing that inspires people. Um, at the same time, we also are the United States. We tend to make things into a business. And so individuals in the United States are adept at holding two competing views about healthcare. On one hand, healthcare revolves around sacred compact between patients and clinicians in local institutions. On the other hand, healthcare is a business that operates on regulated market principles. That doesn't always reconcile well because the need for profit will force doctors and nurses to see more patients and squeeze them in when that's not what they want to do. And that may not even be the right thing to do. So this is my take. It's just my opinion. It's not, I literally put this on the slide, my opinion. Overall, the US has an A-A system of both medical care and biomedical science. Truly some of the best in the world. I mean, people who are rich and sick outside the United States tend to come here when they really need care, especially complicated care. So great medical care, biomedical science and research. We have a C-A system of healthcare, and healthcare is all the things that finance, organize, pay for, and deliver that great medical care. So we have all these for-profit insurers that impose burdensome prior authorization mandates on clinicians, pharmacy benefit managers between drug companies and patients that extract their own tax, electronic health and medical records, which a lot of clinicians, it just makes their day so much harder than it should be. All of those come together for a grade of about C or C-. So we have this disconnect. Great medical care, great biomedical science, very mediocre to poor system of paying, financing, organizing, and delivering it. And you talk to a lot of clinicians and they will tell you the system, I love how she puts it, the system just adds more and more to doctors and nurses and other allied health professionals' days. It just gets so burdensome and bureaucratic, in part because you have all these different insurers with different forms and different ways of getting paid as opposed to one system that standardizes it all and makes it efficient. We have the most inefficient administrative system for paying for healthcare. And this doctor says, you know, there's no villain in this. There's no person trying to do this. It's just a result of administrative creep. One additional task, one more electronic health record you can fill out. But the cumulative effect of that is that doctors and nurses are spending more and more time staring at their machines. And this speaks to this tension. Money-driven medicine. We don't want to make medicine into a big business. But this is America, and that happens. And so if you want to click on this and watch this documentary, if you haven't already, Money in Medicine analyzes this tension in U.S. healthcare between, and the example they use is UCLA, which is, you know, characterized as a very revenue-oriented, high-quality medical system, and they contrast it with Intermountain in Salt Lake City, which is much more mission-driven and as high a quality, if not higher, than any place in the United States. But in so doing, it almost undercuts its revenue because the better a job it does at getting people healthy and keeping them healthy, the less people need complicated care and they don't make as much money. So it's weird that the better you provide medical care and the more you do prevention, the less money you make. Third key fact, and I mentioned this already, Medicare is the key program to keep your eye on. You can't necessarily specialize in all the different programs and health insurers, but if I had to choose one, I would choose Medicare because Medicare has the prices. And Medicare is a big payer. So most health providers build their systems around complying with Medicare. And then everybody knows what Medicare's prices are, so they negotiate from there. So if you want to follow the healthcare system's twists and turns, become a Medicare person. Key fact number 4, and I've had to revise this since COVID-19, and people are losing their jobs. And in the United States, when you lose your job because of an accident of history, you often lose your health insurance. You get your health insurance in this country through your job, which doesn't make sense now. It sort of made sense back in the 1950s. So we're stuck with it. But we have a large portion of our population is uninsured. And when they need care, They have to go get it at the emergency room usually. And then when they can't pay, their costs are then shifted to all the people who do have insurance. This is called cost shifting. It's the glue, the lubricant, whatever you want to call it. It's the thing that keeps our system from just unraveling and exploding. Is that we rob Peter to pay Paul. We charge more to people who have health insurance to cover those who have inadequate insurance or no insurance. And that adds to the gamesmanship of hospitals and doctors and other medical providers charging more than what the care actually costs because they have to get it from somebody to pay for the people who can't pay. Point number 5, power law distributions. You'll always see the world differently once you understand the 80-20 principle. 20% of patients account for 80% of the costs every year for every company, every population. They come up with this graph every year. The top 20% of patients count for 80% of the cost. In fact, even within that 20%, 5% of Americans account for 50% of the cost, which means what you already know, which is that most people don't need healthcare in any given year. They're fine. But every year, a number of subsets of people need a lot of care. And when they do, they rack up huge, huge costs. And where does the bulk of all that huge spending go? It goes to hospitals. That's just the most expensive part of the healthcare system. So if you can keep people out of the hospital who don't need to be there, that's how you save a lot of money. And this is Dr. Jeff Brenner, who's became famous for what's called hot spotting, like finding out who those 20% or those 5% or that 1% of patients that cost so much money, and going out and keeping them healthier, taking care of them, and going upstream to their homes and sending social workers and nutritionists and social nurses, anybody to help them live healthier lives and stay out of the hospital. Now, he's a hero in some ways. He inspires people. In any other system, like the British National Health System or the French or the German or the Canadian, any system that has a budget that pays for care, anybody who saves that system a lot of money would be promoted to president, lauded, career advanced, everything. In the United States, he's just kind of a cool guy who cares a lot. But we don't have a system that says, way to go, you saved us all a lot of money and you provided better care, we're going to promote you and we're going to have other people be inspired and they're going to do the same thing. He's just neat. Right? Now, UVA is trying to do this more and more. A lot of health systems are really mining their data to see who's costing them the most, or who's costing the health system the most. And how can you go out and just find who these, the 3% of patients at the university constitute 30% of readmissions within the first 30 days, while the majority of the remaining 70% return within a year. Most patients, if taken care of well and who are compliant, they're not going to cost you a whole lot. It's always a minority of patients that are going to cost you a ton. Now, here's the difficult thing. Treating people differently is important. It has to be done. You need to focus on that 5%. It's the right thing to do economically and financially. But try treating people differently, and you're going to get people really upset. So to imagine students at the university, the only way we can let older students register first, which seems unfair, like why do they get to register for courses first, is that eventually all students will become older students and they'll get the advantage. But imagine if every year we just let some students register early for no reason, and we didn't extend that courtesy to students at some point. There was no guarantee that they would get it. That would be really unfair and people would go crazy. And I'll prove it to you. Let me show you what happens when you treat people differently.
So that's the experiment we did. Recently, we videotaped it with new monkeys who had never done the task, thinking that maybe they would have a stronger reaction, and that turned out to be right. The one on the left is the monkey who gets cucumber. The one on the right is the one who gets grapes. The one who gets cucumber, note that the first piece of cucumber is perfectly fine. The first piece she eats. Then she sees the other one getting grape, and you will see what happens. So she gives a rock to us, that's the task. And we give her a piece of cucumber and she eats it. The other one needs to give a rock to us. And that's what she does. And she gets a grape. And she eats it. The other one sees that. She gives a rock to us now, gets again cucumber. She tests the rock now against the wall. She needs to give it to us. And she gets cucumber again. So this is basically the Wall Street protest that you see here.
This is the dilemma. I hope you all can hear me. This is why Obamacare is not that popular of a program. It only gets mildly popular when Republicans threaten to repeal it. The core of a program like Obamacare is that it targets the populations that need help, that are uninsured, generally speaking. The bulk of the benefits of a program like Obamacare go to those most in need, but the financing of it has to come from someplace else. And when you rob Peter to pay Paul, when you take from one group to benefit another, no program like that is ever going to be wildly popular. The only programs that are really popular in the United States are things like Medicare and Social Security, where the majority of the population pays into it over the course of their lifetime, and the majority benefit from the program. It's universal. Any program at the university level, at the family level, at the national level that benefits one or treats one group differently is always going to arouse this opposition and this resistance. And that's what makes health policy so hard, because if something like Obamacare comes along, the whole country doesn't need to have a completely new healthcare system. The Clintons tried that in 1993 and 94. That didn't go anywhere. You can't jettison an entire system to build a new system. So Obamacare comes along and says, look, we got about 15 to 20% of the population that needs better access to care. And that's what Obamacare does. But in so doing, you're treating one group, benefiting them, and not doing a lot for the majority of the population, doing some, but not a lot. It's not going to be popular. And another reality, healthcare is not free. It sounds like, oh, duh, Professor Mays, thank you for teaching us that this summer. But these studies show that whenever you expand insurance, the thinking before these studies was, well, get people insured, they'll stop going to the emergency department and we'll save money. That might be true eventually, but within 1 or 2 years of doing that, costs don't go down. These people still keep coming to the emergency department and they end up using more care. So it just goes back to the saying that there's no free lunch. If you're going to make reforms that expand coverage, great. I mean, we need to do that. We're the only country that doesn't cover everybody. Anytime you want to extend a benefit and be more generous, that instinct is great. But as any economist or any person who has a budget will tell you, it costs money. More, it doesn't, later on, you might be able to save money by keeping people healthier. That's true. The more investments you make in people's health and well-being down the line, they'll be employed more, they'll pay more taxes, they'll use the system less. All of that is true. And I can show you research after research. And so, I mean, it's also just common sense. The more you invest in people, the healthier they are, the more they thrive, the better taxpayers, the better citizens, the better consumers they will be. But the money comes up front. You got to do those investments up front. And it's got to come from somewhere. So why can't we have this grown-up healthcare conversation? We're having one right now on this lecture. But it's hard to have that conversation because people get so geared up and argumentative about their side. The reality is, all of these things have trade-offs, and you're going to see that day after day, that if you want to expand this or do more of that, great. If you want to repeal the legislation because you're anti-Obamacare, well, then you've got to own the consequences of that. And that's what Republicans found after Trump was elected, that they've been saying repeal and replace for 6 years, but then when they actually had to own it, they got scared because rightly, people were going to be upset with them. So click on that for a grown-up conversation, which we're having already, which is great, and I'll see you for the next class.
You have stopped screen share.